welcome to our second week in this particular series on health equity and cardiovascular risk. A reminder not to disclose any PHI during any of the case presentations. These are our usual reminders about assistance. All of us are available at any time if you have any technical or scheduling issues or any content issues as well. A bit about Cardio. It's 7 years since we were founded, and had a lot of success since then. You can read about it on the Cardio website. Today I'll be facilitating as usual. We'll talk about today's session in a moment. And this gives you the range of participants from across the state. So Kathleen will be talking about updates in diabetes management. And we have a great combination of Kathleen and Jim to talk about the case study that Sarah will be presenting a little bit later on this morning. So usual disclosures, I don't think there's any changes recently. And the theme today is promoting diabetes control, critical issue. I was just in clinic yesterday, and I'm not doing a great job of controlling diabetes control for some of my folks. So I'm looking forward to this session. So Kathleen, take it away when you're ready.
Great, thanks. Really happy to be here today. This is obviously my passion. I'm an endocrinologist, so I manage diabetes every day. These are the objectives that I was asked to cover. Really looking at some of the barriers that our specific populations face, some alternatives to newer medications for patients who have limited financial means, and describe the use of continuous glucose monitoring and effective strategies for promoting uptake among minority populations. So as you just alluded to, Gautam, managing diabetes is really hard, and we haven't really made a whole lot of progress over dozens and dozens of years. And so this is NHANES data. You can see here when we're aiming for an A1C of 7%, only about half of patients get there. Now this is from 2018, so a lot of progress has been made since 2018. And even the reduced targets of A1C of 8%, we can't get everyone there. And this is even more troubling when you look at some of the specific subpopulations. Younger patients in particular, they are going to be living with diabetes the rest of their lives. So they are going to be really likely to experience some really adverse outcomes. And sadly, we don't do any better with them. So about maybe 50–60% can achieve an A1C less than 7. And all of them really should be getting an A1C less than 7, if not lower. And by comparison, blood pressure control, we achieve a little bit better than that, although not exclusively in about 3/4 of patients. So it is more difficult to reach targets with diabetes, and probably more so when you have multiple comorbidities. So what are the barriers? There are a whole host of barriers that are common to chronic diseases in general, and they're felt pretty acutely in persons with diabetes because it's so heavily based upon behavioral factors, whether it's diet, lifestyle, exercise, or medication taking. And all of these kind of really play a role in terms of how you interact with your healthcare team, whether you trust, your healthcare providers and or just medication in general, side effects, and how much other kinds of outside support you have. On a provider level, and we're all aware of this, the time constraints, and if you look at the latest ADA standards of care and what you're supposed to do to provide comprehensive care, it's literally impossible in a regular visit. But sometimes we don't establish clear goals. We might have concerns about side effects or patients' abilities to manage, and sometimes that's right, and sometimes not so much. And then the system-based barriers are absolutely critical if we don't have population health initiatives in place to support our teams and team-based approaches. And then other, payer issues like, formularies, so transparency in those processes. And the social determinants of health are absolutely critical, and in persons with diabetes. And I've provided a lot of examples here that specifically are important for persons with diabetes, but also common for other chronic diseases as well, and things that maybe we weren't always even thinking about. Race, in terms of race and ethnicity, we see implicit bias, and one of the I'll give you some examples with continuous glucose monitoring. There are issues with, caregiver roles and, just access to a healthy environment, access to healthy food, transportation. All of these are so critical in being able to self-manage diabetes. The social support we're also finding is increasingly of increasing importance, and even just loneliness. Stigma can be very common, and persons can get type 1 and type 2 diabetes confused, but nevertheless, weight isn't the only thing that causes you to have diabetes, and neither is sugar intake. So what are some of the things that have been done? There's an initiative launched by the American Diabetes Association a couple of years ago to help overcome barriers. They're calling this therapeutic inertia, and there are some different definitions of therapeutic inertia, which I won't have time to get into. But in general, these are I think, pretty well kind of understood that we should be setting some having some patients set goals and timelines, empowering patients using empowering your team members, so having ready algorithms and protocols, so it's not just you, the provider, that's managing everything, using technology to adjust therapies between visits, and having sort of some readily available resources. These are common themes with our ECHO series. System-related barriers. They also provided some additional recommendations that we've also discussed in other settings, including especially providing diabetes self-management education and support. And it's a really long word because it's not just education. We shorten it to education, but it's not quite really just what those programs are intended to provide. They're also providing solutions and support for patients. So we know about the pharmacologic management guidelines, and hopefully everyone's familiar with this strategy for providing all that foundation of lifestyle and social determinants of health support, and then determining whether the person has some particular comorbidities like cardiovascular disease and chronic kidney disease. Those patients should really get GLP-1 and SGLT2 based therapies, and then get additional therapies as needed to get their glucose levels to goal. And if not, then really the focus has really moved away from just, okay, start with metformin, then add sulfonylurea, then add this, or what, yada, yada, yada. It should be really thinking about agents that have adequate efficacy to achieve glycemic goals and also to maintain them, and in concert with this, weight management goals. So these are kind of several-fold, and also often mean that we're using GLP-1 based therapy and SGLT2 inhibitors, and also, still a whole lot of metformin. So what about when cost is a barrier? For our Medicaid patients, the medications are free, so really not so much. But a lot of patients who have these, who have insurance but have horrible copays, or have no insurance and no ability to get insurance. And so this is very common. About half of patients have diabetes have financial stress, and a good number of them have cost-related insulin underuse. So they are rationing their insulin, and assuming other medications as well. And most of them don't ever report this to their healthcare providers. So I think you really have to have, a high index of suspicion that this may be going on. And so these are some of the low-cost medications that we often overlook, perhaps, but just kind of going back to what are some of the kind of pros and cons of these classes of medications, and how we can make them, work for these patients. So, our old standby, the sulfonylureas, we still are used quite a bit, and they're preferred for those patients with monogenic diabetes. They do have shorter durability, so you have to be really mindful that they're going to fail within a few years, typically. The glinides are kind of similar. They're more flexible, maybe less hypoglycemia because of that, but add complexity. The thiazolidinediones are generally underappreciated. They have a pretty strong durability compared to either metformin or sulfonylureas, so they don't fail very early. They have some probable cardiovascular benefits. We think, it's been demonstrated with stroke and also metabolic liver disease, and then well-known side effects, and that's a tendency why we tend not to want to use them. So I generally, when I do use them, use kind of the lower doses. And then our alpha glucosidase inhibitors, which are an old standby. I don't use them that often at all because they cause gastrointestinal side effects, but some people, it could be an option for them as they don't cause weight gain or hypos. And so this is what was demonstrated with the UK-PDS data. This is, kind of our, hallmark clinical trial establishing glycemic control of importance in persons with type 2 diabetes. And you can see in 1997, using these older drugs, getting an A1C from 8.5% down to 7.9%, so about a 6% or so difference. You can, over a 5-year period, see changes in improvements in risk of microvascular complications. And then if you follow patients after the end of the trial, another 10 years post-trial, you start seeing emerging reductions in myocardial infarction and all-cause mortality. So that takes quite a long time to establish benefit for those cardiovascular endpoints. So these drugs can be effective in preventing complications, and so we shouldn't just, because we can't give them the newest, fanciest drugs, ignore therapy altogether. So this is some comparisons of some of these lower cost drugs in terms of 3-point MACE, or major adverse cardiovascular events. In this meta-analysis, you can see compared to whatever was the comparator in the trial, which may have been active drug or placebo, that there does seem to be some benefit of metformin, surprisingly, and pioglitazone, but perhaps not so much with the insulin secretagogues like your sulfonylureas. And then on the second panel there, there's not really much difference in mortality across all of these groups for the newer drugs, or for the older drugs. For the newer drugs, of course, there's well-established benefits in mortality. The secretagogues also kind of hovering on the right side of that line. So I think if I'm going to focus on older drugs, I might actually favor more for metformin and pioglitazone on the right folks, but just also recognizing that when you have to use them, you have to use the older drugs to get patients to goal. And so insulin is one of the most effective, cheaper medications, especially now that Medicare patients in particular can get their drugs for no more than $35 per month. And with that, the recent changes to with the Inflation Reduction Act, if there are low-cost programs through manufacturers where you can also get these insulins for relatively cheap. Probably the cheapest programs that I've seen are just kind of getting vial and syringe from Walmart, so there's some prices there. Test strips and glucose monitoring supplies continue to be pretty expensive, and so you can see some of the cheaper ones there, but it's really quite limited because there aren't as many programs. And when we're using these older insulins, the NPH and regular insulin, we have to remember, try to get those on board early before the meal, 30 minutes before ideally. So here's kind of here's in this ugly green here, this is kind of the typical insulin profile with meals and basal. And so when you give regular insulin, it's peaking way late. and hangs around for a really long time. Here's the NPH, when you're given both NPH and regular insulin in the 70-30 mix. The NPH sort of kind of covers lunch a little bit and then kind of wears off by supper. And then here's your second dose here of regular insulin and NPH. So you can get, peaks and valleys at times that maybe you don't need them. So sometimes you need to have a bedtime snack. And sometimes you have to have a very small lunch. So you're avoiding kind of highs and lows. So there have been an explosion of use of CGMs. The technology has really changed incredibly over time. And with this has become a change in the way that we're recommending their use, and payers are covering it. Initially, there were a lot of barriers and hurdles, and it was implemented in such a way that you had to have diabetes education and already be demonstrating that you're poking your fingers 4 times a day for many insurers to pay for it. And so this created a lot of inequities, and you can see this here as an example. This was a type 1 diabetes exchange, which is a large prospective database of over 11,000 patients with type 1 diabetes. Half of them use CGM, and those who use CGM had much better outcomes, including severe, like hospitalizations for DKA and hypoglycemia. But there were these horrible inequities, and they persisted even after adjustment for insurance, meaning that sometimes we as providers are being sort of gatekeepers, or somehow not offering or allowing our patients to take advantage of these devices. So this is described in other studies. One of the most powerful explanations for this that I saw was I just put the quote here because I thought I couldn't write it in a better way. Previous studies have documented numerous potential reasons, including language barriers, access to quality healthcare, and implicit bias. And many young Black and Hispanic adults who had heard of the technology had not been offered it by their providers. And so thankfully that's changed a bit. So, this is one example of rollout in use in persons with type 2 diabetes at a major academic medical center. And you could see that A1C reductions in persons with type 2 diabetes, once you put them on a CGM, and this is no additional drugs, was 1%. Less so with type 1 diabetes. And there weren't any differences. So really good reductions in A1C across different racial and ethnic groups. And really some of the factors that were important was how high your A1C was to begin with, and whether you're seeing an endocrinologist, which kind of makes sense, and whether you're using insulin. Using the ICC framework, this was established by the American Diabetes Care and Education Specialists. We can help promote the uptake but also the continued use of these devices. Helping the person choose the right device. So where they want to wear it, how long they want to wear it, what's the device compatibility, I think is also really critical when you're thinking about trying to implement population health approaches. So if it's not compatible with their smartphone and they can't put an app on their smartphone and then link up with your clinic, that is a challenge. And you're going to be less likely to be able to provide readily available feedback. How the device is configured, making sure that you're not turning on every single alert and having it beep at them all day long, but really strategizing what you're trying to accomplish with the alerts, sharing the data with other people as necessary, education in really helping people learn that yes, your glucose isn't always going to be the same on a CGM and a finger stick. Setting goals and what is a normal glucose level, not reacting or overreacting to every single value. Troubleshooting the device. When is it not accurate? When do you need to change it out? What happens if I'm having a rash? What happens if it falls off all the time? And then also when to do a finger stick. So the last piece that's really important is it's really most useful when you're providing feedback in a real-time basis or at least as needed and reviewing the data together. So this is the ICC framework. This was one example where a practice transformed its processes for implementing CGM. So this was a type 1 diabetes clinic, but I think it is really applicable to other healthcare teams who take care of people with diabetes. They recognized the problem, started having some actual kind of meetings to try to identify what gaps they're having. They engaged they called it a social needs coordinator, but it might be a nurse, it might be whoever's helping with, your access, your paperwork, your prior authorizations. They actually engaged manufacturers, which, you can have sort of a mixed relationships with, but the manufacturers went in and trained their staff in how to download, how to link their, devices, and kind of took some of the pressure off of, the healthcare teams themselves and doing all of the work. And then they had some device trials where they can put people on them and sort of overcome those initial barriers to just what does it look like and actually getting it going. And then they developed prescribing workflows. So those can look like, that's a whole other lecture, but they had really some, established relationships with some of these durable medical equipment companies so that they had, a constant and ongoing feedback loop. And then they provided education and provider bias training. So within this context, sometimes it's really helpful to see how well you're doing. And then these were the results. They were really really amazing. Over the months, you can see how CGM prescriptions soared, about 3/4 of patients, and in particular among Hispanic and Black individuals, and also rose in white individuals, but they were able to kind of bridge some of those disparities. So these are some of the specific recommendations to promote uptake. And so your population health-based approaches, tailoring these programs to individuals, and developing virtual care models. And you typically need diabetes care and education specialists or pharmacists are really amazing and over again been able to implement these programs, incorporating them into a virtual care. So I will stop there. Thank you all.
Okay, terrific. Thank you, Kathleen. Any questions for her? I think there's quite a few in the chat as well. Let me just scroll through these if we can. And Danette was asking, Kathleen, if you've observed a lot of weight gain with the low-cost diabetic medications, I think referring to sulfonylureas in particular.
Yeah, you definitely, not a ton of weight gain with sulfonylureas, and I think it's important to emphasize all of the other things that you want patients to do, and also not over treating lows when they occur. I see a lot more weight gain, frankly, with insulin, I would say, and some of that's just how insulin works, but I also, really try to avoid the hypos and trying to treat to avoid eating to prevent hypos, and rather using the insulin, adjusting the insulin instead. So that can be tricky. Maybe with insulin, and maybe with, if you're using the high dose TZDs, you can see, 10, 20 pound weight gains. And also you got to remember, if they're severely hyperglycemic, they're already, expending calories through glucosuria, and really in other ways would be holding on to that weight that they otherwise would have had. So some of it is due to the insulin itself, and some of it is also artificial because they would have already been, hanging on to those calories.
Thank you. And Misty had a question about a free program at OSU for the more expensive medications. This is something we struggle with here in Northeast Ohio as well, but if you could kind of let us know what sort of programs you have.
Yeah, so we have a medication assistance program. It's kind of slow and clunky, but it does go through different manufacturers for all of these medications. There are, individuals though that they just fall through the cracks because their income is too high, or they have, maybe there are, not U.S. citizens, or and so they don't qualify for these programs. And so there are still some delays when you try to use the MAP programs. And the Medicare, is a good example. There's still people who have, pretty high copays and maybe don't qualify for these programs. So you're sort of stuck.
Thanks, Kathleen. I had a question that came up early on in your talk, and it was about younger patients with type 2 diabetes and the challenges of controlling them. So putting my sort of other hat on, from the child and adolescent world, the thinking is that type 2 diabetes in adolescence is an especially malignant phenotype. It's extremely aggressive. If you get type 2 diabetes at 13 or 14, you could have complications in a much shorter time period than if you got, if it was someone who was 50 years old. Do you see that with young adults as well? Have you seen that?
Yeah, yeah. It can be quite malignant, as you say, and some of that is that they actually have, just severe, phenotypes of type 2 diabetes, but you also have to be careful that you're not missing underlying latent autoimmune diabetes or type 1 diabetes. And when you have a mixture of the two, much higher risk of developing complications at an earlier basis. So I would tend to be, pretty aggressive with those, and they've got all other things. They're kind of trying to grow up and live their lives, which are, incredible barriers as well.
Thank you. Any final questions before we move to our case?
I've got a quick one, if I may, Dr. Rao. Kathleen, thank you. Your information obviously is pertinent and useful, particularly so I've had the opportunity to lead a series of diabetes education classes for some of our clients here at Southeast. We're going to be starting another series of classes in March. I saw a lady yesterday. I see her routinely. I do the finger stick, and I help her with her continuous glucose monitor. I have noticed, at least with this particular lady, her blood sugar yesterday was great. It's 119. But I have noticed readings with her continuous glucose monitor appear to be about 20 points higher continuously. I don't want to assume anything without evidence. Is that something you've noticed? Is there a continuity in the difference between the readings you'll get with finger stick and a continuous glucose monitor?
It's certainly possible, but it's more often because there's a sensor failure or a transmitter failure, especially if they've been doing okay for a period of time and then just start having unusual readings. And you could try, if it's something that's just ongoing that has been consistent, I suppose you could try just changing to the other device if they're on a Freestyle Libre, switching to a Dexcom or something like that, to see if that solves the problem. And then just anytime you notice a discrepancy, advising them to do a finger stick just to confirm. And Karen may want to add any of her suggestions too, because I'm sure you deal with this all the time.
I actually do. I actually wear the Freestyle too. And I noticed that the GMI on my Freestyle is higher than my actual A1C when I go get labs drawn. So I think there may be something to that it's a little bit higher. But what I'll tell people is, like if I had a gestational person with gestational diabetes and they're supposed to monitor their sugars fasting and 2 hours postprandial, 1 or 2 hours, and they're wearing a sensor too, I'll say, use the sensor to learn about trends and how your foods and activity are affecting your glucose. And then when you go to document your postprandials, go ahead and do a finger stick. Especially if it's above goal and you just want to double check. If it's in goal, use the sensor reading, but if it's above goal, do a finger stick. So, I still think the CGM is so valuable. And then ask her about vitamin C, because with the Freestyle Libre's high doses of vitamin C above 500 milligrams can lead to false readings.
I actually think if there's a discrepancy between the A1C and the CGM, that more often than not, the CGM is more accurate.
Oh.
Yeah, because there's so many things that affect the A1C, but there are some really weird things like, patients who have, Raynaud's and they have, microcirculation, they're weird cases, but more often, yeah.
And then, of course, if they're hemoglobin or they have anemia. I
Yeah,
had
right.
yesterday that
That's-
had an elevated A1C, but she also had anemia of, during pregnancy, her hemoglobin was low, so.
So anyway, Missy had a final question. I'm happy to answer it. Insights on psychiatric medications putting weight on in adolescents. This is a huge issue. At one point, we had 3 million American children and adolescents on atypical antipsychotics. I think that's come down a lot, but all of them, even the supposedly weight neutral ones, such as aripiprazole, do stimulate appetite. And of course, sometimes you see substantial weight gain with those medications. It can be mitigated early on through educating parents and with metformin, but that's a whole other discussion for another day. But thank you, Misty. So with that, let's turn things back to Andy for a moment.
Just as a reminder, we have all past and present echo recordings online. Next slide. Our upcoming cardio webinar is on the 28th of this month. You can register at cardio.org or through the QR code. Next slide. And then you should have a post-clinic survey in your inbox. Please complete that by tomorrow at 5. As Gautam said, please submit case studies if you haven't already. We would love to get a schedule out soon. And then just email me if you have any questions.
Okay, thank you, Andy. Thanks, everyone. Have a wonderful rest of the week, and we'll see you next week. Take care.